This is Josh. Oh, hello everyone. This is Josh Levitsky, coming to you from Northwestern School of Medicine in Chicago. I'm joined by my co-moderator Alberto Sanchez-Fueo, who's at King's College in London. And today we are going to be reviewing two papers as part of an AJT Tcmr series. And in this webinar, we're going to be focused on two papers in liver transplantation that have been published in the last few years in AJT. And we actually did this, one of these webinars already a few weeks ago that's available on YouTube. It was timed more appropriately for Asia and Australia. And so hopefully the US and Europe, this is a better timing to participate in this live webinar. So I want to introduce our panelists. Let me just shrink my picture here. We've invited back Jake Dimitris, who was on our last webinar, who's a professor of liver transplant pathology at University of Pittsburgh Medical Center here in the US. And then we have two European hepatology colleagues, very well published and esteemed in transplantation. Maria Lodano, who is at the hospital clinic at Barcelona, Spain, and also Eleonora de Martin, who's a hepatologist at the Paul Brousse Hospital in Paris. So I'm going to turn it over to Dr. Sanchez-Fueo to introduce the two papers that were already published or have already been published and presented on this recent webinar.
Thank you very much, George. So the two papers we are going to be discussing today are the ones shown in this slide. The first one is entitled Outcome and Safety of a Surveillance Biopsy Guide Personalized Immunosuppression Program After Liver Transplantation from the Hanover Medical School, where the senior author is Dr. Taubert. And then the second paper is coming from Phil Halloran in Edmonton and is entitled The Molecular Diagnosis of Rejection in Liver Transplant Biopsies, the first studies of the INTERLIVER study. So both PIs have had the chance to present these two papers in a pre-recorded session that was uploaded in YouTube, and that we are hoping that the audience had an opportunity to view. Now, there is a particular reason why we decide to choose these two papers. We think that they complement each other very well, and they actually bring what we think are very, very relevant discussion points to tackle today. And this slide here just kind of we've just providing as a framework for the discussion that we want to undertake. But well, I mean that this is perfectly open, and we are hoping that the audience will also be asking questions to the chat, and we will be able to somehow shape these discussion points. But I think that there are areas that certainly are worthwhile kind of mentioning today, such as whether kind of a surveillance biopsies are really helpful in liver transplantation, how relevant it is subclinical T-cell mediated rejection. Is there a role of molecular profiling in the management of liver transplant patients? Can we use non-invasive biomarkers to potentially replace biopsies? And ultimately, what do we think could be the best approach to actually refine the way we manage patients long-term? So, okay, so let's kind of start the discussion. I'm going to make the first question, and we thought that we would kind of focus first in the paper from Dr. Taubert in Hanover. So I'm going to address this question first to my clinical colleagues, Eleonora and Maria Carlota, but then I would kind of like to hear Jake Dimitris' view as well. And the question was the following. So, you've had a chance to kind of review Dr. Taubert's paper, and the proposal is quite kind of novel in that surveillance biopsies are being used to directly guide the use of immunosuppression relatively shortly after transplantation. So my question is, are you actually convinced that surveillance biopsies can actually improve management of liver transplantations? And if this is not the case, which are the aspects of the paper that you think fail to make the point that surveillance biopsy should be used to manage immunosuppression? So you want to start, Eleonora, for instance?
Okay. Thank you very much, and thank you for this opportunity. It's great to discuss this two papers with you today. I really believe that there is a role of protocol liver biopsies in the surveillance of liver transplant recipients. I think this paper enhanced this role that have been diminished in the past few years. And in our center, we still perform protocol liver biopsies at 1, 2, 5, 10, 15, 20 years. And so my pathology colleague, Dr. Sebag, already published a paper on the 20 years protocol biopsy. And she compared the 90 patients who had the biopsy compared to the 56 who did not have the protocol biopsy for any reasons. And the interesting findings was that in patients who had the biopsy, there was a significant increase in immunosuppression compared to the patient who did not have the biopsy, who had a significantly decreased immunosuppression. So basically, if you look at the histological record, we found abnormalities, and we tried to correct these abnormalities that we think in the most of the cases are linked to a lower dose of immunosuppression. So I believe this paper is this good point to enhance the role of biopsy, and also to show clearly a well-standardized protocol to manage immunosuppression. Because what we are currently doing is just, of course, we do the protocol biopsy, we see the report, we discuss, and we make the changes, but it's very difficult to clearly show a protocol on this. We do it in a clinical practice. And so this is, the good point. I think the limit is that in this paper, you do not have follow-up biopsy. So you don't really know the impact of their immunosuppression changes on histological changes, like possibly subclinical rejection. So I think very strong point, and this I think maybe is one of the limitations of the paper.
Maria Carlota?
Yes, hello everybody, and thanks also for the invitation. So we did a similar study in our hospital, trying to see if we find some histological lesions in patients with normal liver tests after 10 years of liver transplantation. And we also found that approximately 60 or 70% of the patients had abnormalities in the liver biopsy, and even we found patients with cirrhosis. So well, at that point, I was convinced that these protocol biopsies were useful, but I'm not sure if we need to do protocol biopsies in all the patients to decide whether we should decrease immunosuppression. No, maybe there are some patients in which we can easily say that this patient is over immunosuppressed. We can decrease immunosuppression without the need of histological findings. For example, in patients with complete normal liver enzymes and patients with very low FibroScan, as Alberto and Julian showed in their paper last year. But maybe in some difficult patients, we can do protocol biopsies to guide immunosuppression. For example, patients with autoimmune liver diseases or more complicated patients, just to be sure that they don't have liver abnormalities that can impact the immunosuppression minimization. But I think it's a question, I think, without a clear answer. And I think the paper by Taubert is very nice, because no, they show that it's kind of useful, but I think we need more data, and we certainly need, as Eleonora mentioned, follow up of these patients that they decrease or increase immunosuppression guided by the histological findings.
Before we get to Jake, because I know what Jake is going to say, get tissue. I just wanted to ask Maria Carlota, I didn't get this, but do you do surveillance protocol biopsies in Barcelona?
No, we don't.
Okay.
We did many years ago when we were facing patients with hepatitis C, but not anymore.
Yeah.
So we just doing in context of studies.
I just want to mention what maybe Alberto can mention what is done at King's, but we've started to do this. There are two groups of patients that we've been doing this on. This gets back to your point, Maria, is that sort of the specific population to select that maybe most benefit from protocol or surveillance biopsies to optimize immunosuppression. So we have our pediatric group has been doing this regularly every 3 to 5 years. And then when we get them as transition as adults, we continue that until they're about 30, 35 years old. And then we sort of stop doing it. And I think part of it is that that's a higher risk period between 18 and 30 years old for non-adherence, but also immune activation and rejection. So we've continued that basically on all of those patients, but we have just started to implement protocol biopsies in autoimmune liver disease at 5 years post liver transplant, even if their labs look good, because as we know that even with normal labs, if they have inflammation and they're an autoimmune patient, that they probably should have an increased immunosuppression because we know that can progress. Although I don't really have data to support that, we just feel it's sort of the right thing to do. And of course, now that NASH is obviously very prevalent everywhere, we've generally been kind of screening with FibroScan, and if there's a high stiffness, that's not really a surveillance approach, but it's sort of using as you mentioned, the FibroScan to identify potentially a problem, and then we do that in our NASH patients. So we just started to explore that. So it's a little bit of a middle between both of you, kind of more of a select group. I thought maybe Alberto, I think it's good to discuss because most places don't do this, right? I mean, probably I would bet 95% of liver transplant centers around the world do not do, adult centers do not do surveillance liver biopsies.
Yes, in our case, we do surveillance biopsies as part of the pediatric liver transplant program, but not in the adult side. And the kind of children who eventually become adults, they have their surveillance liver biopsy program stopped as soon as they are transferred to the adult service.
Yeah.
So Eleonora, before we ask Jake, you've mentioned that in this analysis you did internally, those recipients who had surveillance biopsies, they actually had overall their immunosuppression strengthened. Is that correct?
Exactly. Yep.
Okay, so I think that's a very interesting thing that I think we should come back later. But Jake, do you have a sense that the use of surveillance biopsies improves patient care?
I do, because I think if you're at the proper center, it gets the pathologist involved in the process. And I think for protocol biopsies, the spatial context of what you can derive from the tissue is very important. And liver transplantation is far away from being a finished product. You know, one of the areas of quote growth and investigation is going to be chronic antibody mediated injury to the allograft, not only microvasculitis, but how you can get agonistic activation of stellate cells through antibodies. So without the tissue, you're going to be struggling to make more advances. The question is, I think, how often do you do the biopsies? And I think that should be stratified by patient. You know, if they have metabolic diseases, they have one biopsy at say a year or 2 years that's normal. I probably wouldn't go every year. I would space it out much longer than that. But in my impression that it adds, the other thing that is an important part of this equation that I hear from my clinical colleagues all over the world is that pathologists got to get off their butt and do a better job on the pathology and add more value, because that's the criticism that I get from a lot of hepatologists and some surgeons.
Maria Carlota, do you want to comment?
Yes.
Yeah.
Sorry, no, I completely agree that the pathology results are very important. And we also see what you mentioned. When we biopsy patients later after transplantation, we see some changes that maybe suggest this chronic no antibody-mediated rejection. But the problem is that if we do these surveillance biopsies, we don't know yet what to do with the findings. So should we increase immunosuppression in the patients with the findings that you just described? So we don't know if doing this increase or leads to a change in the histological findings or change the survival of the graft and the patient. I don't know what you think about that.
I was curious. I was going to ask Eleonora, actually. I'm glad you were about to speak up, but I really, I sort of wanted to pose the question, and is that, I mean, if you have a 65-year-old patient, you know, this is our average age is now 60, and I'm sure in Europe it's not too different, with metabolic syndrome or alcohol, never had rejection, and has normal liver enzymes. Do we still consider a surveillance biopsy to guide minimizing them? Because if you see some inflammation there, increasing their immunosuppression may have negative consequences for that type of patient. So sorry, I didn't mean to interrupt, but I had to kind of pose sort of the yin yang here.
No, I totally agree that maybe it's the one that you would increase a little bit, or at least do not decrease. Let's make it in this sense, at least not decrease in the patient you're describing right now. Mm-hmm. But once again, with pathology, you have like really a variety also of lesions and features. You have another paper, it comes from 10 years ago, but you can see veno-occlusive liver disease, and we saw that if you increase immunosuppression, that the surveillance biopsy performed afterwards was better, at like improved histological features. You have nodular regenerative hyperplasia. We still do not know exactly what this feature comes from, and this is an immunological, for example, damage. So it's sometimes very difficult and intricate. And I agree with Professor Demetris that it's the only way to learn. So I
think this is where studies come in as an important component, you know, sponsored studies that have long-term follow-up in them. They're hard to do, but I think that's what's needed. Because the areas that are really unanswered questions is the clinical significance and long-term consequences of a low-grade Tcmr, flow issues. The liver, transplanted liver, sees a different blood flow than all the other organs, because the portal vein brings most of the blood and it's regulated by the nerves and they're gone. So if you talk to surgeons, they said it's like experience a fire hydrant coming through, and you do that for 25 years, it's going to have some traumatic effect on the blood vessels. And as I mentioned before, the antibodies and what's the interaction between those components.
So check this issue of the low-grade Tcmr, which is probably what we think that we are seeing in many of these abnormal inflammatory findings in surveillance biopsies. Now, you did with Sandy Feng and the study where patients who were considered non-eligible to participate in a drug withdrawal trials were rebiopsied. I think it was 5 years afterwards. So how much worse was the histology 5 years afterwards in these children, most of which had this form of kind of a probably low-grade Tcmr?
Not much, and most pathologists would consider them minor changes. You know, particularly the ones that were considered non-tolerant by biopsy, meaning they had increased activity. But when you do a complete minimization trial, the ones that I've been involved with, people always complain about the pathologist is raising issues for non-significant findings. But my take on the issue is that when you do a complete minimization trial, you want to assure patient safety, that these people that are out 5 years, you don't forget about them and they're off of immunosuppression and they indolently reject their grafts. And then the other one's a scientific argument about sensitivity and specificity. So if your criteria are too loose, you end up studying low-grade rejection instead of what you think might be leading to tolerance.
What I find interesting about these tolerance studies in pediatric and adult is that we've probably learned more about the patients who are not candidates than those who are, the smaller percentage that are candidates and that successfully become tolerant.
Right.
Because when you biopsy a lot of people, and then you all have done a lot of the work here on kind of characterizing, molecularly and outcomes of those patients who are not eligible, which is going to be the majority of our patients, right? Because most of them are going to have findings that make them ineligible, and some of that is, and those are actually selected people too who make it to the point of getting to that biopsy. So it's just kind of.
But I think moving forward, long term, you're going to be able to use the non-invasive approaches like Alberto suggested to do a primary screen, we'll call it, before they even get considered for the study.
So in the Hanover paper, in addition to the surveillance biopsies, they also included the donor-specific antibodies as one of the parameters to take into consideration when making decisions as to immunosuppression. So I'm curious in Barcelona and Paris whether you actually use DSA at all in the long-term management of your transplant patients.
So we do as part of a study that is being going on by and is led by Jordi Colmenero. And so we test all the patients with rejection or suspicion of having a rejection with DSAs, but we don't monitor DSA at specific time points. So we do that just a part of a study, but we don't change the management of the patient because of the presence of the DSA or not yet.
So speaking of Jordi, I have a question from him actually for the panelists, which is a bit of a loaded question, but I just want to get your opinions. He asks, what is your opinion on the best type of non-invasive biomarker to select those patients who should undergo routine liver biopsy or maybe minimization? Cell-free DNA, microRNA, mRNA, or more simple clinical elastography DSA data?
Well, I think I will go for the simple thing to select the patient for the biopsy, and we will do non-invasive biomarkers. But of course, I don't have a lot of experience with cell-free DNA, and maybe Josh, you want to comment on that because you have generated some data.
Yeah, I think what the studies that we've done in mRNA and cell-free DNA have a very high negative predictive value for the presence of current or future rejection. So we kind of look at it as a potential way to risk stratify patients when considering minimization. And we're actually going to be doing a large multi-center study using these markers in tapering patients off calcineurin inhibitors after transplant. And both cell-free DNA and mRNA profiles seem to be quite good at that. The problem is if they're elevated with normal liver tests, we don't know. I mean, there is some indication that it may predict future rejection, but it's not as good. So the question is, do you do a liver biopsy when you have that, when the liver tests are normal? Or, I mean, this is really kind of more serial immunosuppression management, not because you can do it in the blood, not, you can't do FibroScan every time you change things. And of course, biopsies can't be done that regularly too. So my opinion on Jordy's question, I agree with you, Maria, that I think implementing elastography, or at least we need studies to correlate that with biopsy findings and outcomes, in my opinion. We need more data, but I think, and again, FibroScan, my prediction would be that it would have a pretty good negative predictive value if it's normal. And I think you all showed that in your study. I think in Journal of Hepatology, that a real normal FibroScan with normalish liver enzymes predicts kind of the absence of inflammation. So I think a lot to be answered here and a lot of different biomarkers, but I think the idea here is to maybe try to use them more in serial practice than ever before in managing patients, and maybe a screening test to perform, a biopsy, just as you mentioned, something more that you can regularly do. But it needs to be proven in prospective studies for sure.
Yeah.
Right. So in Paris, we do DSA, but we do not really guide our choice on changing immunosuppression based on that. If there is no histological, also antibody-mediated rejection, C4d positive staining, and blah, blah, blah. So it's not just the only marker that will guide us in changing the immunosuppression. We're doing it like regularly in case of sign of rejection. We are starting doing more regularly, like in the follow-up, like coupled with the protocol of biopsies. But still, I agree that if you want to screen for the biopsy, you can start with non-invasive markers, but they're not, at least in my experience, precise enough, or at least they won't give you all the information I think you need, at least right now.
Mm-hmm.
Can I ask something to Eleanor? I'm sorry, because I just had a quick question about if you treat different the rejection that is associated with C4d staining and DSA as compared to the rejections that are not. Did you use a more potent immunosuppression in that rejections?
Yes. So if we really believe, so it's rare. That's the first thing to say. So I saw it, but it's really rare. We had a couple of cases that were really high DSA for C4d positive staining and also like morphologic signs of antibody-mediated rejection. In that cases, we use plasma exchange and IVIG. So we never used rituximab or other more potent drugs, but we change our management in those patients. Yeah.
I think the obviously the entity that Jake and the Banff group described, and I'm sure we'll have an opportunity to discuss this again in September, but the entity of kind of chronic AMR, especially those where you see plasma cell rich infiltrates, I think we probably will see a lot more of that the more people you biopsy. And you may see C4D, low grade and some DSA. And sort of the question in my mind is in a chronic setting, meaning, late after transplant, not in an acute AMR, And the question always is, what do you do about that? You're not gonna, someone chronically probably pherese them, give them rituximab, be aggressive, but how do you prevent it from progressing? I think that's a major question. Maybe you add another immunosuppression agent and rebiopsy them later, but it's not quite clear. I don't know, Jake, if you have thoughts on that, because you were.
I think we need better agents. And the other concept that I want to raise is that antibody-mediated rejection, particularly chronic, has been narrowly defined as microvascular inflammation. If you don't have microvascular inflammation, you don't have an endothelial cell signal, antibodies aren't contributing to the process. And for the liver, that's probably not going to be the case over the long run for a couple reasons. One, anti-stellate cell antibodies can directly activate stellate cells in an agonistic fashion and cause fibrosis. We showed that from a study in Dallas. And also, the liver is the only organ that has already intravascular macrophages. If you see intravascular macrophages in the kidney or heart, you say, well, that's AMR. Well, Kupffer cells are lining the liver and they clear activated complement. But when macrophages clear complement, they're also better allostimulators. So you're looking at a whole cycle and a whole different way of looking how antibodies interact with the tissue. You know, another example is when people have bile salt export pump disorders and they don't have the proteins on their canalicular membrane to export the bile. You put a graft in, they develop antibodies, they get cholestatic, there's no microvasculitis at all, but they respond to steroids and plasmapheresis. So we have to broaden our concept of how antibodies can interact with liver tissue.
So I think this is a good opportunity to move to the interliver study, because one of the probably striking findings in this study, when compared with all of the other work that Phil Halloran's group has performed in kidney, heart, and lung transplantation, is the absence of a transcriptional signal typically associated with antibody-mediated rejection in the case of liver transplantation. So would you interpret these findings, Jake, as just a proof that the antibodies interact in a completely different manner in liver allografts as compared to anything else?
No, because they can also cause macrovasculitis. It's uncommon. I'll bet in a series of large that was included there was some antibody-mediated rejection in there. You can actually calculate out the percentage. If your program does 100 livers a year, maybe 15–20% will have antibodies, and out of that, another 10% will have high enough to cause damage. So you should see about 1 case a year, 1.5 maybe. That's it. And a lot of programs are smaller than that, and then they're expecting a lot more. So I think they're in there, and I think the way the cases are analyzed makes it harder for it to raise its head among the statistics, the statistical approach to the way the genes are analyzed, particularly the unsupervised analysis. You know, if I picked 5 cases of, fluoride antibody-mediated rejection, I'm sure you're going to get a signal, and you get an endothelial cell signal, but it's mixed up into the population statistics.
So we review our experience at King's since the publications of the 2016 BAMP criteria for AMR, and in fact, that was our prevalence: 1 case per year, 5 cases in 5 years. Well, that would be even lower because we do 200 adults a year. But these were actually the cases of confirmed or suspected acute AMR. Right. And I remember, Jake, a number of years ago, you had selected a very well-characterized cohort of antibody-mediated rejection cases from liver recipients, and you were going to do transcriptional profiling. Have you managed to do these experiments, and are you actually seeing something similar to what has been reported in pure AMR cases in other organs?
We haven't done it yet. I've got the cases together, but we haven't done it yet. And we also do ABO incompatibles here as well. And we've seen when for one reason or another, they forget to plasmapherese the patients below baseline levels. We have a handful of cases of AMR due to ABO incompatibilities. That, that's an ongoing program here in Pittsburgh.
So I wanted to ask Maria, Carlota, and Eleonora on how to take the interliver study and see how this could be helpful in your clinical practice. Say you are going to proceed in doing, well, Eleonora, you're already doing surveillance biopsies, but say this is starting to increase, which I can kind of foresee the future as more centers will be implementing this. Do you think the molecular profiling is going to add anything as far as looking at the results of this paper? And I guess the question is, when you sit down with your pathologists and you're concerned about rejection, and we know that rejection is not always classic Tcmr where it's quite obvious, but you see other things that we're referring to here, different cell infiltrates, vascular injury, etc. Do you think there's enough cases of those where a molecular profile may secure a better diagnosis and help you, or are you not sure yet?
I mean, just based on the paper, probably I'm not sure yet, but generally thinking, I think it adds something. I mean, the more you have, the better your diagnosis will be. So if you have the transcript that can help you and make the difference, for example, between the Tcmr and the injury. And I found one thing it was really interesting, this slope, the fact that the injury was in the archetype analysis, I think, archetype and Tcmr was like lowering in the time. So meaning that the lesion you find in long-term run are different, and probably you should manage it in a different way, because it's true that we are talking about managing. We have like 4 molecules, and we're just playing with that, and we do not, I mean, and we just try and we are not sure. So if we can improve our diagnosis with this transcript and understand that the long run lesions are different, so I think it would add something, definitely.
I think that having more information is, of course, good, not to help us dealing with things, but I think that in the clinical practice currently, really we just need a good pathologist to diagnose the T-cell mediated rejection, because now that we don't have hepatitis C, that what was the main problem when we were facing hepatitis C recurrence, we had a lot of problems trying to see if the patient has a recurrence or it was a T-cell mediated rejection. But now I think it's easier to, I think, for the pathologist to diagnose a TCR mediated rejection. And I think the main issue in which I thought the paper was going to give us information was about the antibody mediated rejection, because we don't have the clear findings to be able to diagnose these problems. And so I think that currently for clinical practice, I don't think it's necessary the way it is, and with the data that we have, and just facing a normal rejection. Of course, when we face difficult rejections that they don't respond to the typical immunosuppression, and maybe we are thinking if maybe this patient has an antibody-mediated rejection, it will help, but this data didn't show that. But well, then I can ask a question later about the signature, maybe to Dr. Demetrius. But this is my opinion in the clinical practice.
Jake, what do you think?
I still think that because of the expense in liver transplantation, the molecular profiling is more of an investigative tool that should be iterated with the clinical findings and the biopsy findings. I think just doing and saying, well, pathology is problematic and we're going to get all the answers from molecular profiling is not the best approach, in my opinion. I think looking at all of the modalities, the serology, the biopsy findings, the clinical findings, the immunosuppression levels, to help move the test forward. And I've had the most success iterating among the various data sources and trying to understand what's going on in the tissue and how the graft's being affected by the immune system. So I'm an advocate for kind of all the above approach, but for right now, routinely doing mRNA analysis on all biopsies, I don't think it's clinically warranted.
I'm just curious, do you think in other organs it would be more helpful than in the liver, or do you think the same goes for heart, kidney, lung?
My experience with the heart is kind of similar to what it is in the liver. The kidney, it's a little bit more helpful, but again, it's more of an investigative tool to iterate back to develop tests rather than looking at the whole profile. I mean, eventually you could raise the theory that if you do millions and millions and millions of samples, that it will even reveal spatial relationships. But, that's way down the road. And that's why I'm an advocate for doing, multiple modality testing.
Of course, in kidney transplantation, some of the studies from Phil Halloran show that the transcriptional profiling correlated with long-term kidney function better than histology, but in liver, we don't have creatinine to actually make this type of correlations. So I think that the implementation of this type of studies in liver, if the same strategy is used without central pathology, is probably going to be much more complex than what it has been in kidney transplantation.
Yeah, the kidney, especially as an organ, is, much more fragile than the liver is. And if you're familiar with it, it's a kind of a pessimistic downward slope. There's almost one direction that it goes. If it gets inflamed, it gradually deteriorates. That's a generalism, but it's also generally true. Whereas in liver, you can get a big insult and the liver will bounce back and look normal. And, the variability in the biology of the organ is much, much different.
But it's interesting, and I know in kidney from my colleagues who are designing studies to include centers that do protocol kidney biopsies. I had originally thought, oh, everybody's doing them. In fact, it's only about a third of kidney transplant centers in the US do surveillance biopsies, despite the clear association of subclinical rejection and progression in kidney transplant, where we don't even have that in liver, not clearly, but in kidney, it's fairly clear. But I think it's just a patient preference, logistical issue that is probably the problem for centers to be doing it regularly. And that's going to similarly apply to our patients too. In liver transplant, not wanting to have regular biopsies done, which makes this whole thing kind of challenging. So
I think the time scale is a little bit different for kidneys and liver. We do protocol kidney biopsies at 3 months and 1 year, and they're very helpful. Patients are doing fine, the creatinine's fine, everything's fine. And at 3 months, you see significant rejections that they, get a hold of and get control of. But in any organ, getting off on the right foot, if you can, is the best for long-term survival.
I have a question. So if you do not perform the biopsy and you decide to lower the immunosuppression because you feel it's safe, wouldn't it be a risk to develop like chronic AMR? So you start developing some antibodies and then sort of that it's going to be a little bit too late because and maybe is why we're starting to see some of the lesions, because compared to the past, we are trying to lower and lower the immunosuppression.
I I definitely think it's a risk. And a lot of the weaning studies people develop, DSA, they're followed for 5 years. You don't know what happens at 10 years. So
I think the question is kind of what I brought up before, which is what patient population could this be beneficial in? Because certainly, if you augment immunosuppression, there could be a worse outcome than just minimizing and not, maybe they suffer a complication of cancer or whatever related to, keeping immunosuppression too high, then the concern for, progression of rejection, of like a chronic AMR or something. So I mean, this needs to be teased out, but certainly I think the younger, the immune patients, the people who've had rejection before, when you just try to, tinker with their immunosuppression, those are the ones that I would worry about and probably should be the focus of our studies, I believe. I think, in terms of biopsy-guided approaches, although what's interesting about the Hanover trial is that they actually use this, and the most successful were the group that had everything negative, that they were able to really minimize and calcineurin inhibitors and improve creatinine. Well, the other side of it could say, well, we probably would have done that anyway without a biopsy. So it's complex. And I think it's not clear exactly what the right approach is, but I personally think it's a risk stratification, and maybe it's using non-invasive parameters initially and also patient phenotype to decide whether to do a biopsy, because you want the biopsy to be helpful and guide what you're going to do. You want to have a response to it, and I think that's what's nice about the Hanover studies, that they clearly had a very detailed protocol and management strategy with multiple inputs on what to do about patients' immunosuppression based on their strategy. I think that's why this is quite unique.
Yeah, I thought another strong aspect of their study was it was kind of all adult comers. They had autoimmune disease, they had everything, and a lot of studies, they exclude the higher immunologic risk patients. Now, other point I wanted to bring up is, particularly in the United States, and it's probably becoming more true and throughout the world, is the, kind of low-grade NASH is the new normal. And that really complicates monitoring and the pathology and everything. It's just a new normal. And people don't realize you kind of have to incorporate that into your studies and everything that you do with the patients.
And looking for a potential indication for molecular profiling, do you think that this new normal provides an enough degree of histological uncertainty to potentially justify a companion molecular approach?
Yeah, and that's why I say, looking at the molecular profiling as an experimental tool or, a translational tool is very important. There's now evidence from Germany that there's autoimmune activity normally in NASH, autoreactive T cells in NASH. So, will you be able to molecularly profile and squeeze that out from rejection, or are they going to mix together, or do you need, T cell receptor sequencing or whatever? So yes, molecular profiling as a powerful new tool, but just, applying it to every patient in every setting doesn't, to me, it's not the correct approach.
You and I have always talked about this, Jake, which is, in the immunosuppression weaning studies like AWISH and Optimal, the patients sometimes who were weaned off or very low on immunosuppression had a steatohepatitis kind of develop, which makes you think maybe low-grade immunosuppression important to keep on these patients. And maybe there is an interaction between the innate and T cell, responses, and post-transplant NASH is kind of different than general NASH. Or,
Right.
I mean, I'm not suggesting we immunosuppress all of our NASH patients, but it makes you think that there's, it's not just the steatosis and the ballooning, but there's an inflammatory response.
Right.
Yeah.
I think there is a question from Elmar Jekyll in the chat. We always look for DSAs in the context of antibody-mediated rejection. Could they just be a sign of uncontrolled autoimmune responses, especially if de novo?
I mean, that's always the rationale that people raise when they say antibodies doesn't matter or don't matter. And that's the rationale most hepatologists give for the autoantibodies. Oh, it's just a biomarker of immune activation. But if you see C4D deposits in the microvasculature and microvasculitis, and you have to concede at some point that it's playing a pathogenic role. It's not just a biomarker. If you turn that 180 degrees around, you can't say that it's not a biomarker, though. It is giving you a serum warning that something is wrong.
Well, I think what's interesting, and correct me if I'm wrong, Alberto, in the group, is that really in weaning studies, it's not the baseline DSA, it's during the weaning that when DSA develops is the problem. Is the baseline, sometimes patients who are deemed tolerant at the end still have DSA but have clean biopsy. Are they really tolerant? So, but it's really during the weaning that kind of predicts failure, rather than the baseline. I don't think any study has really shown a correlation of baseline DSA and failure. It's really during the weaning.
Correct.
Right.
Yes.
Yeah.
At baseline, of course, we exclude those with underlying inflammation,
Yeah.
and then we are probably excluding those in which the antibody is really either having a direct pathogenic role or somehow is a sign of a really robust cellular immune response. So these are being excluded. So
That's true.
antibody at baseline is no longer a predictor of outcome.
Yeah.
Yeah, it's kind of a selection bias.
Exactly.
Yeah, that's true.
And in your study, Alberto, because one of the approaches is to use transaminases and DSA, so it's it's important in these non-eligible patients as a marker of.
Unless your ALT is 8, then you don't need anything but that,
Yeah,
right?
Yeah.
Yes.
But not many do, especially in the United States. Other factors lead to that, higher ALTs. We don't see it that often.
I think that what the studies indicate is that DSA is simultaneously kind of not serving two purposes, but they can be a marker of two different things, either just a biomarker of a T cell response, but potentially a mediator of direct pathogenicity. In the setting of this kind of a very selected recipients with normal liver function tests, none of these patients have C4D deposition. So in this case, we are using DSA just as a marker of donor-specific T cell responses. There are, of course, many other pathological situations where, in combination with clear histological signs and C4D deposition, I think that it's difficult not to believe that the antibody is not actually playing a direct role.
Well, I think we're at the top of the hour. We could keep going, but I think we have to stop. Really like to thank Alberto as my co-moderator for both of these. Both were, I think, both webinars had different perspectives, a lot of common themes, but it was good to hear everybody's thoughts about these papers. I wanted to thank Jake, Eleonora, Maria Carlota for joining us today, and I hope everyone enjoyed the discussion. So thank you, everybody.
Okay. Bye.
Bye.
All right.